Hi, Dave Lockwood here with Percussionaire Corporation. You might have seen some of our previous interviews, and if not, I'm a respiratory therapist and a clinical specialist for Percussionaire Corporation. We've been asked by a lot of facilities to explain if we've been using our Percussionaire products with COVID-19 patients. And if you've seen our other interviews, the answer is yes. And this is a continuation in that series. Our guest today has experience with using the IPV and the VDR ventilator with not only COVID-19 patients, but with H1N1 patients. So with that, I'd like to introduce our next guest, Jeff Helpborg. Jeff, tell us a little about yourself.
Hey, Dave. My name's Jeff Helpborg. We've been using the VDR now for the last 15 years. We have an adult rescue program where we do mobile ECMO, and we will go out and put patients on ECMO. But the interesting part is we also have a bronchotron, and a fair amount of those patients will go on the transport version of the VDR, which is the bronchotron, and then come back to our hospital and not need ECMO. And this is kind of really started in 2009 with H1N1, and we've moved forward with this device in many different disease processes. And so we have used both the VDR and IPV in the treatment of all disease processes.
So with COVID-19, have you been doing IPV therapy on these patients, or has it been mostly with the VDR ventilator?
I see. I think for us, like many hospitals, when COVID first came out, there was a lot of worry about creating any type of aerosolization. And so our first and foremost attack was with the VDR, right? And not so much IPV. It's interesting in that I also keep tabs on several other different hospitals throughout the West Coast, to include most of California. And many of those hospitals, I think, actually started with IPV and COVID a little bit sooner than we did. And so we do some IPV, but I think it's more VDR. And I think, like all of us, we are trying to do our best not to intubate those COVID patients.
That's been my experience actually when I was most recently working in a per diem capacity. We found out that when we gave IPV therapy to patients, it started with patients who were on high flow nasal cannula. We found that probably 75% of the time we did not end up intubation of those patients. And so we developed a protocol where if they got onto a high flow nasal cannula, they automatically got IPV therapy, usually Q6, and found it very, very effective. So tell us about your experience with the VDR ventilator then with these patients. And people will want to know if you, because with the COVID-19 and the quote aerosolization, obviously these patients should be in a negative pressure room. You should be wearing proper PPE. And I know some facilities said they were usually using a leak technique, but with COVID-19, they found that they would just inflate the cuff unless it was a secretion or a CO2 evacuation issue. And they found it worked just as effectively. What is your experience?
Yeah. So for us, our thought process of the VDR creating that accelerated laminar flow and then creating a turnaround, there's been a very good CO2 removal device for disease processes. So I don't start with the cuff down. And in fact, I rarely have the cuff down. I would say 90% of our patients. And Legacy Systems is an 8-hospital system. There's a standalone adult and children's campus side by side. We just don't traditionally start with a cuff leak. The hospitals that I talk to in the Kaiser system in California, Sutter hospitals, we just don't start off with that cuff leak. The cuff leak can help with a little bit more CO2 removal, but it's not a starting point. So it's not as big of an issue for us with COVID in general. Because of COVID, we typically do not have a cuff leak anyway, and that is fine. I think where IPV has been a bigger part for other hospitals in my area is IPV in line with a ventilator, and sometimes helping recruit that area of the lung that I just may not be able to get with conventional ventilator because of the flow that the treatment device provides.
Have you found with the COVID-19 and the VDR ventilator, are you, as far as controls on the vent, are you finding anything different than any other patient that would be on the VDR? Or are you pretty much managing it the same way you would if it was just, say, a ARDS case?
Nice. So I will start with the legacy hospitals, and then I'll expand to a few of the other hospitals. And again, I'm in a unique role in that I'm a clinician at the legacy system, and then I work for another company that takes care of the Northwest. And so for us at Legacy, a lot of our COVID patients have been secondary, ventilator patients have been secondary to our adult rescue team, where we will go to areas close to Seattle, central Washington, all over Oregon, and go get somebody that is very close to not surviving and put them on ECMO and bring them back. They go on the VDR in that scenario, but now the ventilator becomes more of a device to just gently try to keep their lungs a little bit open as we go through the ECMO cycle. So we have had a lot of very high acuity COVID patients. And so for our opportunities to really push that accelerated flow to see if we can recruit may have not been there because it came back to us on ECMO. And so then it's in the weaning process that we'll use the device, and hopefully they've gotten somewhat better on their time of ECMO to be strong enough to go back to conventional ventilation and eventually extubate after being on the VDR. It's a really different experience compared to H1N1. These patients, when they've gotten sick enough to be considered for ECMO, have been a tougher patient, I think, to deal with. Now, the facilities in Northern California that are using the VDR, they have had pretty good success with using it with a little bit higher PEEP than I might have used in the past, but being more close to whatever kind of PEEP they would use with their ARDS program. There are sometimes the ability to use the same amount of PEEP as a conventional ventilator, but have an overall lower mean airway pressure, which has been helpful at times. And again, I say this all the time, this vent has not been a magical unicorn for this disease process, but it gives us another tool in our toolbox to help patients that are not responding to conventional ventilation. And the key for, and I think there are 7 hospitals here on the West Coast that are using the VDR, is trying to use it early on in a COVID patient for your best chance to recruit the lungs and then see if the patient has any other comorbidities.
Yeah, one of my other interview guests said that they went from using the VDR for rescue with COVID-19 patients, and now if they're COVID-19 and they get intubated, they just start right on the VDR ventilator. And in his experience, he feels that it has shortened the length of time, although the time on the VDR is longer, more days than they normally would see. It is a shorter time, he feels, than if they were on conventional ventilation. So
Yeah, I think that's pretty fair. I think, again, I'm going to split experiences. But the legacy system, because they're an ECMO system, and the vast majority of our COVID patients have been ECMO patients brought in from our transport team, that is a little bit different type of an acuity of patient that you have to take care of almost as where you're going to use the ventilator to try to just gently keep their lungs a little bit open, versus the hospitals that are seeing these patients early on in the case, right? And that's your opportunity. And I really don't care what ventilator technique you think is best. We believe that the VDR can be one of our best tools, and so we try to use it as early as possible. It is not meant to replace a conventional ventilator. It's meant to partner with it when you set standards of where you think a conventional ventilator may not be helpful anymore.
Do you know, you said you haven't done a lot of IPV yourself with these COVID patients, but do you know of any other facilities that you stay in contact with that have been doing IPV treatments with COVID-19 patients? And are they doing the normal 15 to 20-minute treatment, or are they doing them longer?
Yeah, good question. I think that there is a facility in California, Santa Clara Valley, that they have done, they've had interesting stories. They've had patients that have been very sick, and other ECMO centers have not been able to accept them for one reason or another. And so they've added IPV to these patients. Now they've done it continuously, which is another technique to consider with this device. They've added it, and according to them, they've had 3 or 4 patients survive. A facility in Fresno area that's a big children's hospital that has absolutely added IPV, and more importantly, they've had 3 pediatric COVID patients, which is not a common thing. We have not had a bunch of intubated COVID patients. We had a couple at our children's hospital that seemed to respond quite well, but we just have not had very many. But this institution has been using the VDR with some success with those patients again.
Good to hear. Yeah,
So,
I've heard from some facilities in Europe where currently, if they had VDR ventilators, they can use them, but we're currently not available for new purchases in Europe due to some CE regulations that we're addressing. But I've had these facilities tell me that they've used IPv2Cs and giving anywhere from, say, a 60 to a 4-hour continuous treatment with very effective results on these patients. So as most people know, the technology behind both of them is high frequency percussive ventilation, whether you're doing it as a therapy with IPV or if you're doing it as a form of ventilation with the VDR.
yeah.
From reports we're getting back, people that are used to using our equipment, they feel very good and feel that in some situations, the patient, if they didn't have access to this technology, would have expired. So
I think without a doubt, I think in 2009 with H1N1, it was clearly evident. We absolutely were rescuing patients when nothing else would work conventionally, and they were brought to our facility. It was phenomenally successful, and it continues to be extremely successful in those types of patients. And the specific physiology to talk about it is for another time. I think with our COVID patients, we have had some success, and I think there have been some patients definitely at other facilities where they do not have access to ECMO, or could maybe not get to an ECMO center in time, where they used the VDR and used it at pretty aggressive settings and were able to help that patient when nothing else at their facility would work. And I think we have a couple hospitals in Bakersfield that have had several success stories in their adult population. And it was going to be very difficult to try to get them to another center of care in time. And so they use this tool to try to help those patients.
very good. Well, it's been great talking to you. Any other insights you can give me if someone was not using the IPV or VDR, but they had the equipment? Is there anything you can add to that? Or
I think that if you are seeing lots of infiltrates or areas of atelectasis and you don't have a VDR, you start with IPV. You have a tool that provides that accelerated flow that can possibly get in that area of lung and reopen that area of lung up. And because it's producing that counter current flow with each pulse, possibly remove debris. And it gives you another tool to try to just keep that patient's lungs open and then see where things go for that patient. It is a very good tool that can be added to our repertoire to try to help these patients.
yes, thank you. All right. I appreciate your time. I know you're busy, and I appreciate you taking this time to explain your experience with the VDR and the IPV therapy. Thank you very much, Jeff.
All right. Thanks, Dave. Talk to you later.